Chapter 12 concerns psychological disorders and begins with a conversation about what is normal or what is considered to be abnormal. Now, there are a number of different approaches to defining what we call normal, but of course none of those is perfect because no behavior is universally abnormal. There are some behaviors we call infrequent. Those behaviors are displayed by the greatest number of people that are considered normal. Statistical infrequency considers behavior that is atypical or rare to be abnormal. However, some behavior that is rare, such as creative genius or extraordinary language skills, or even world-class athletic ability, is valued. Therefore, statistical infrequency alone in those categories will not be an adequate criterion. We have norm violation, which simply suggests that people who behave in ways that are bizarre or unusual or even disturbing, sometimes those behaviors violate social norms or cultural rules and are called abnormal. There's also the notion of personal suffering. Psychological problems causing distress require treatment in some cases, and because some of those people with disorders may not experience distress, personal suffering alone cannot be the only criterion for abnormality. And there's a practical approach to how we look at behavioral psychological disorders. For example, the content of that behavior, whether the behavior is bizarre or dysfunctional or perhaps even harmful, the socio-cultural context in which the behavior occurs, or basically where and when the behavior occurs. The consequences of that behavior are all taken into consideration when judging whether behavior is abnormal. A practical approach also considers whether behavior causes impaired functioning. Cultures and subcultures determine which behaviors are quote-unquote appropriate for a given situation. Now let's take a look at a couple of ways we might be able to define psychological disorders using specific models. First of all, let's take a look at the biopsychosocial model. That model looks at abnormal behavior being caused by a combination of interaction between biological, psychological, and sociocultural factors. For example, biological factors. The ancient Greek physician Hippocrates introduced a medical model in which he explained that psychological disorders resulted from imbalances among four humors. The medical model eventually evolved into the concept of mental illness. The medical model is now termed to be the neurobiological model because it looks at problems in anatomy and physiology of the brain and other areas. Psychological processes, as another model, suggest that difficulties are caused by inner turmoil or other psychological events. Psychological models include the psychodynamic, socio-cognitive, and the humanistic approaches. From a sociocultural context, that model relies on factors such as gender and age, physical and social situations, cultural values and expectations in historical eras. Cultural general disorders appear in most societies, while culture-specific forms appear only in certain sociocultures. Another model is what we call the diathesis stress model. It's an integrative explanation. According to the diathesis stress approach, genetics, early learning, biological processes, and stress levels may all contribute to psychological disorders. Next, let's take a look at how we classify psychological disorders. Generally speaking, those of us who practice in the behavioral world use what's called the Diagnostic and Statistical Manual. This particular edition that we're working in now is version 5. It describes each form of disorder and provides criteria for those particular diagnoses. The DSM-5 also provides evaluations on different, what they used to call axes. Those particular axes have been converted into other areas. Those particular diagnoses have to do with psychological disorders themselves, cognitive concerns, as well as emotional factors. So let's take a look at the diagnostic system in general. The major goals of a diagnosis are to help individuals to identify appropriate treatment for clients and to accurately and consistently group patients with similar disorders so that research efforts can move more easily and identify underlying causes of mental illness. Now, there are two limitations of diagnosis. The first is validity, and the other is inter-rater reliability. Inter-rater reliability is the degree to which different diagnosticians give the same label to one patient. Let's take a look first of all at anxiety disorders. We'll start with phobias. A phobia is simply an anxiety disorder that involves a strong, irrational fear of an object or a situation that should not cause such a reaction. Specific phobias involve the fear of specific physical objects or places or activities. Social phobias involve the fear of being negatively evaluated by others or publicly embarrassed by doing something impulsive, outrageous, or even humiliating. Agoraphobia is a strong fear of being separated from a safe place like home, or of being trapped in a place from which escape might be difficult. Generalized anxiety disorder is a condition that involves milder but longer lasting feelings of anxiety, worry, dread, or even apprehension that are not focused on any particular object or circumstance. Free-floating anxiety is a term sometimes used to describe the non-specific nature of this anxiety. Panic disorder. Periodic episodes of extreme terror, we call panic attacks, often occur without warning or any obvious cause and are characteristic of people with that particular diagnosis. Obsessive compulsive disorder, or OCD in some cases, is a persistent intrusion of thoughts or images or a compulsive need to perform certain behavioral patterns that are symptomatic. When the obsessive thinking or compulsive behaviors are interrupted, severe anxiety results. How many of you know individuals who count any number of things? I've mentioned before, at my own home, there are 15 steps that go to the second floor of our house. There's also 15 steps that come down. I know that because I count them every time I go up, every time I come down. The difference between that particular compulsive behavior and a disorder is that my behavior of counting the steps does not interfere with my normal and daily function, which is one of the criteria that constitutes a disorder. What are some of the causes of anxiety disorders? Biologically speaking, there can be abnormal levels of particular neurotransmitters or oversensitive brainstem mechanisms. From a physiological perspective, a person suffering from an anxiety disorder may exaggerate the danger associated with certain stimuli and underestimate his or her coping ability, which causes anxiety and possibly depression. Now, there are some links between anxiety disorders and learning. Phobias start with distressing thoughts followed by operantly rewarded behaviors. Phobias can also be emphasized or explained by classical conditioning. People may be biologically prepared to learn certain fears and avoid stimuli that had potential for harm or to our evolutionary ancestors. Rare phobias may be a product of classical conditioning, but common ones, such as the fear of snakes, fire, height, and insects, may be due to a biological preparedness to react negatively to certain potential hazardous things. A second class of disorders is referred to as somatoform disorders. These are disorders that deal with the body itself. They're characterized by physical symptoms that have no apparent physical cause. In conversion disorder, a person appears to be, but is actually not, functionally impaired. For example, they may appear to be blind, deaf, or paralyzed, but in reality they aren't. Now, the physical symptoms often help reduce stress and anxiety, and the person may seem most unconcerned about them. Hypochondriasis, or the act of being an hypochondriac, involves strong fears of a specific severe illness that are usually accompanied by complaints of many vague symptoms. In the notion of a somatization disorder, a person makes dramatic but vague reports about a multitude of physical problems rather than any specific illness. Pain disorder is characterized by serious, often constant pain with no apparent physical cause. There are also another class of disorders referred to as dissociative disorders. They're characterized by sudden, usually temporary, disruption in memory, consciousness, or identity. A dissociative fugue is characterized by sudden memory loss and the assumption of a new identity in a new locale. In dissociative amnesia, a person has sudden memory loss without leaving home and creating a new identity. The most dramatic and least common dissociative disorder is dissociative identity disorder. It's formerly known as multiple personality disorder. This disorder involves having more than one identity, each of which speaks, acts, and writes differently. Psychodynamic theorists believe that dissociative disorders are methods of repressing or forgetting unwanted impulses or memories. Behavioral theorists also believe that dissociative disorders are examples of learned behavioral patterns that have become so discrepant that a person may feel like and be perceived as a different person from time to time. Dissociative identity disorders are currently appearing more frequently in society. Recent studies have drawn several conclusions about people displaying multiple personalities. Many of those folks have experiences they would like to forget or avoid, such as child abuse. Many are also skilled at self-hypnosis, and most can escape trauma by creating, quote, new personalities to deal with the stress. Next are mood disorders. They are also referred to as affective disorders, and they're characterized by persistent, extreme mood swings that are inconsistent with environmental events. For example, depressive disorders. Major depressive disorder involves feelings of sadness, hopelessness, inadequacy, worthlessness, and guilt that persist over an extended period. Also common are changes in disturbances in eating habits, sleep, decision-making, and concentration. In extreme cases, depressed people exhibit delusions. A more common pattern of depression is dysthymic disorder, which involves symptoms similar to those of major depressive disorder, but to a lesser degree and spread out over longer time periods. One factor related to significant depression is suicide. Repeated bouts of depression and suicide are closely linked. Interpersonal crises, intense feelings of frustration, anger, or even self-hatred, the absence of meaningful life goals, and constant exposure to stress are associated with suicide and depression. Student populations, the elderly, and females have a higher incidence of suicide than the general population. Those who say they are thinking about suicide are much more likely to attempt it than the general population. Along with mood disorders like depression, we also have bipolar concerns. Those disorders are characterized by alternating feelings of extreme depression and mania over a period of days, weeks, or even years. Bipolar I disorder is relatively rare in comparison to major depressive disorder. Even less common is bipolar II disorder, which features major depressive episodes alternating with less severe manic episodes. Cyclothymic disorder is no longer listed in the DSM-5 particularly, but it's slightly more common and has a pattern of less extreme mood swings. What are some of the causes of mood disorders? From a biological perspective, altered levels and possibly dysregulation of norepinephrine and serotonin, which are neurotransmitters, changes in the control of the stress-related hormone cortisol, abnormal biological rhythms, and genetic influences are causative factors for affective disorders. There is strong evidence that bipolar disorders may be inherited. From a psychological and social perspective, traditional psychodynamic theorists believe that people with strong dependency need turns. In fact, they turn inward, and feelings of worthlessness, guilt, and blame that are really meant for other individuals get placed on themselves. Behavioral theorists believe that people become depressed when they lose important reinforcements. Learned helplessness can also be a causative factor in depression. Social cognitive theorists believe that negative mental habits, such as focusing on and exaggerating the dark side of events and being generally pessimistic, and attributional styles can also lead to depression. Another very interesting disorder is called schizophrenia. Schizophrenic symptoms include severely disturbed thinking, emotion, perception, and behavior, which impair a person's ability to communicate and function on a daily basis. Statistically speaking, schizophrenia is rare, occurring in only about 1% of the population. Improvement is more likely if a person has achieved a higher level of functioning before the symptoms originally appeared. Now, what are some of those symptoms? People with schizophrenia often display incoherent forms of thought. For example, neologisms or word salads, clang associations, and loose associations are common symptoms. Schizophrenic thought content is equally disturbed. Common symptoms include ideas of reference and thought broadcasting, blocking, and insertion. As an example, 2 weeks ago I had a client in my office who was convinced that there were bugs crawling along the floor up against the wall. Trust me, there were no bugs crawling up against the wall on the floor. But he did think very seriously that such insects were there, hence his schizophrenic diagnosis. Other symptoms of schizophrenia include the inability to focus attention or to concentrate. Changes in perception of body parts or of other people may also occur. Many people with schizophrenia report hallucinations or false perceptions. Emotions are often absent, what we call a flat affect, or inappropriate for a given situation. Movements may range from constant agitation to almost total immobility. Lack of motivation and social skills, deterioration in personal hygiene, and the inability to function from day to day are also common characteristics of schizophrenia. Now, there are a number of different subtypes of schizophrenia. If you're curious to learn a little bit more about those, you can check out that information related to the DSM-5. What are some of the causes of schizophrenia? There are biological factors involved, which could include inherited predispositions, the oversensitivity to dopamine, loss, deterioration, or disorganization of certain brain cells, enlarged brain ventricles, reduced blood flow in certain parts of the brain, and abnormal brain lateralization. Not all persons with schizophrenia have all the biological problems listed. Evidence also suggests that specific symptoms are correlated with specific biological problems. Positive symptoms are associated with an increase in dopamine activity. Negative symptoms are associated with decreased dopamine activity and abnormal brain structures. Now, psychologically and socioculturally, the psychodynamic theorists suggest that schizophrenic behaviors represent a regression to early childhood. Behaviorists believe that schizophrenic symptoms are learned methods of trying to cope with anxiety. They may also be the product of patterns of reinforcement and punishment in early life. A relatively new theory is called vulnerability theory, and the vulnerability model takes a diathesis stress approach. The vulnerability can be biological or psychological in nature. There's also another category of disorders referred to as personality disorders. They are less severe than psychological disorders. Their lifestyles or ways of behaving that begin in childhood or adolescence and create problems, usually for others. 10 personality disorders are described in the DSM. They're grouped into 3 clusters and share very certain features. The odd eccentric cluster features symptoms similar to but milder than schizophrenia and includes schizoid, schizotypal, as well as paranoid personality disorder. The anxious fearful clusters are self-explanatory and include dependent behavior, obsessive compulsive behaviors, and avoidant personality concerns. The dramatic erratic cluster includes histrionic, narcissistic, borderline, main, and antisocial personality disorders. The main features of the dramatic erratic disorders are extreme self-absorption and lack of empathy for others. Antisocial personality disorder is the most serious. It's characterized by a long-term pattern of irresponsible, impulsive, unscrupulous, and sometimes even criminal behavior. When we focus on research methods, it's important to explore the links between child abuse and antisocial personality disorder. If we use a prospective design, researchers have compared 416 adults whose backgrounds included official records of abuse by age 11 to 283 adults without records of abuse. Although a minority of both groups showed criminal tendencies and as well as incidents of antisocial personality, the rate of both was greater for the abused group. The 2 groups were matched on important variables such as socioeconomic status, but it is possible that abuse may indirectly cause criminality and antisocial personality disorder, as abused children are likely exposed to other risk factors, such as poor role models, future research should investigate the possibility more directly. If we take a look at other psychological disorders, there are some that can begin in childhood. Childhood disorders are unique because of the incomplete nature of children's development and their limited coping skills. Most childhood behavioral problems can be categorized as either externalizing, which means a lack of control, or internalizing, over control. Common externalizing disorders include conduct disorders and attention deficit hyperactivity disorder. Internalizing disorders include separation anxiety disorder. Autistic disorder is an example of a disorder that does not fall into either category. Autism spectrum disorder usually appears in the first 30 months of life. These children do not like to be held, have severe difficulties with language, and play endlessly with inanimate objects in their own worlds. There are substance-related disorders. These disorders are the result of prolonged use of or addiction to psychoactive drugs, which can cause physical and psychological harm to the user and consequently to others around him or her. There's alcohol use disorder. Alcoholism afflicts more than 7% of American adults. It is a pattern of continual and intermittent drinking that may lead to addiction and almost always causes severe social, physical, and other problems. Behavioral theory suggests that people learn to use alcohol because it helps them cope with stressors and reduce stressful reactions. Biological evidence suggests that alcoholism may be due to an inherited predisposition, especially in men. There's also cocaine and heroin addiction. 1 million Americans are addicted to cocaine, which is a rough estimate, and millions more use it. Continued cocaine use or overdose can produce a range of symptoms from nausea, hyperactivity, paranoid thinking, sudden depressive crises, and even death. Addiction to heroin is largely a biological process. However, psychological factors may be involved in the initial beginning of drug use. Lastly, let's take a quick look at mental illness and the law. People with mental illness are protected in two ways when accused of committing crimes. First, a person who, at the time of trial, cannot understand the charges or assist in his or her defense. That person is considered to be mentally incompetent. Second, the person can be found not guilty by reason of insanity if, at the time of the crime, mental illness prevented the defendant from understanding what he or she was doing or that the act was wrong, or if it prevented the defendant from resisting the impulse to do wrong. These laws were designed to protect people with mental illnesses, but critics also question the idea of protection. Others point to problems deciding who is insane and who is not when there is conflicting testimony. Some states have actually abolished the insanity defense. Other states now permit a verdict of guilty but being mentally ill. The irresistible impulse criterion has been eliminated from the definition of insanity in federal court, and the defense is now required to prove the defendant was insane at the time of the crime. The latter is also the case in many other states. This is a quick overlook, certainly a broad generalization of disorders related to psychological difficulty. There are many, many others dealing with all kinds of physiological and psychological concerns. If you have an interest in those particular disorders, take a look at the DSM-5, or better yet, cruise the internet for certain and very specific resources related to the DSM-5, which can provide you with excellent information. Until next time, have a good day.